their birth weight and height and length, in the civilian sector, if they've moved around and they haven't stuck with the same hospital. So anyway, but you got to figure out what their birth weight and height is, and if they were SGA and they have not caught up, they're a candidate for growth hormone. This is the workup that you should do before you send them to see an endocrinologist. You want to get the CBC and DIF, looking for chronic anemia like inflammatory bowel disease. I've made that diagnosis multiple times. SED rate, looking for inflammatory bowel disease. A Chem10, again, ALK-Phos, liver kidney test. Thyroids, a urine, looking for DI, which will, they don't grow well. The 2 growth factors, the IGF-1 and the binding protein 3, and then the celiac. And then always get the bone age. Again, girls, the only thing 100% with girls and Turners is short stature, so you got to get the chromosomes. And the kids that we do the growth hormone stim tests on are the ones with a normal screen but a decreased growth velocity. There are side effects of growth hormone therapy, the SCFE, the pseudotumor, transient carbohydrate intolerance, transient hypothyroidism, but it does not cause cancer. We always do a bone age, and people always think, it's the size of their hand. It's not the size, it's their growth plates, right? So a bone age will help you determine how much growth potential they have left. I always say, like, a 10-year-old has more growth potential than an 8-year-old. So if your bone age is 10, that's not necessarily a good thing, okay? So we're looking at growth potential. And based on their bone age and height, you can actually figure out their final adult height. Again, I talked about 10 reasons that you get growth hormone. One of them is they fail the growth hormone test. Their levels are less than 10. Or if one of their levels is greater than 10, they pass. You do like 8 levels. You give them something like arginine, L-dopa, clonidine, insulin, something that's going to stimulate growth hormone, and then you measure hormone levels. One of them is greater than 10, they pass. Turners, renal osteodystrophy, right prior to renal transplant, the kidney doctors will often put them on growth hormone. Prader-Willis will get growth hormone. Bad side effect a few years ago, 9 kids died from it. And the kids seem to be the really severe, heavy, and they think it was maybe their adenoids had grown, and they had sleep apnea. So before you put anyone on growth hormone with Prader-Willi, they never took it off the market. They just said, make sure that you are doing a sleep study on them before you put them on. And if the kid does get a cold and starts snoring, they're supposed to stop the growth hormone. The SGA we talked about, if they hadn't caught up. Adults. We used to say goodbye to the kids when they were done growing. Now we retest them to see if they need growth hormone as an adult. And that's to prevent osteoporosis. Obviously, the dose is like 1/100th of a dose of kids because you would give them acromegalic features, right? So very low dose, but it helps prevent osteoporosis. Noonans, we talked about AIDS wasting. SHOX deficiency. This is a gene that's needed for normal chondrocyte growth, and again, that's the cause of the growth problems in Turners. Also, 1 to 2% of normal, and something called Leary-Wheel syndrome. So SHOX, you can actually measure the gene, see if they're deficient in it. And then there's this idiopathic short stature, kind of the smallest of genetic short statures. I mean, they're on like the 1.2 percentile, so they're well below the growth curve, okay? And when you do their bone age and you predict out how tall they're going to be, the girls 4'11", boys 5'3", so really tiny. So again, the more severe genetic short stature. They've put these kids on growth hormone, and they've grown another 4 to 7 centimeters. Doesn't seem like a lot to me, but for them it's a lot. Doesn't seem a lot to the insurance companies because they don't often pay. Okay, so a lot of times what happens are they'll say idiopathic short stature, they'll be denied. This is the only one that they usually get denied from the insurance companies. Then the drug company will often pick them up for 6 months to a year and give them free growth hormone to see if they have a good response. And then you can go back and reappeal the insurance companies. But when the nurses, I'm like, we need growth hormone for this idiopathic short stature, and I run out the door because it's so much work for the nurses to try and get these things approved. So it is a lot of work. But some of the kids do respond, some don't, and so we're trying to figure out why they do. But on average, 4 to 7 centimeters. So when you're dealing with these kids with short stature, this is a very important slide. Sort of, again, I'm sort of a bottom line person. If you know their growth velocity, their family history, and their bone age, that's all you need. You're going to be able to differentiate the big 3, genetic or familial, the late bloomer, and then the hormone problems. So genetic, they have a normal growth velocity. Their family is short, but their bone age is normal. Okay? Late bloomers also have a normal growth velocity, but their family is delayed, has pubertal delay, and they have a delayed bone age. And then the hormone problems, they have delayed bone age, but they don't grow. They don't have a normal growth velocity. That's all you really need to sort of differentiate the big three, okay? So here's a growth curve. This is a constitutional. We've seen that. Up and down on the growth curve at age 3, they pick their point, and they kind of follow the 3rd to 5th percentile. Right prior to puberty, they have that little bit of a dip, which is normal, and then they grow. Okay, so a normal growth velocity and a delayed bone age, and you would like a family history of delayed puberty. Versus a genetics, God, their growth velocity looks just the same, doesn't it? It's a normal growth velocity. They're moving right along. But their bone age is normal. They don't have any extra potential growth. And the mom and dad are on the smaller side. Okay. Endocrine moving right along, then something happens. They have a decreased growth velocity, okay? So they have a decreased growth velocity, and their bone age is delayed. Their height in the end is going to be variable, and family history isn't always helpful. But when you see that halting of the growth curve, then that's very concerning. But again, delayed bone age, abnormal growth velocity. And these we see a lot of. Usually it's the kids like on ADHD medicines. So they're fine up until age 6, and what happens? They'd stop eating. So they're decreasing their height starting at 6, and then starting at 7, they have a decrease of their weight first. And then starting at age 7, they have a decrease of their height. Okay? So that tends to be systemic. This could be celiac. This could be inflammatory bowel disease. But usually it's nutritional. Okay? I always say, if you don't eat, you're not going to grow. I say that like 100 times. And you need a good night's sleep to grow. Just like Grandma used to tell you, right? But I went to school for 5,000 years to get where I am. So anyway. It was fun, though. It was fun. Okay. Just kidding. So normal, tall people, okay? Tall stature. Familiar tall stature is because your parents are tall. They have tall kids. Except for my daughter. She's a little short. She's learning how to drive, and we have to get in the car, and she has to move. The seat's moving up. It's like, okay, Katie, we're wasting 5 minutes here. So, anyway. She's going to kill me. Nobody knows Katie. Well, some people know Katie, but yeah, it's just fine. Soto syndrome is not an endocrine problem, but the guy, Dr. Soto, he's at Ohio State. I think he's still practicing. He's like 90 or 95. God bless him. But he discovered this. And so he's the endocrine, okay? So these are the kids, like humongous kids, the ones that you hear about like on, TV or in the newspapers or whatever, that, the 40-pound 2-year-old or whatever. But then they slow down. For some reason, they're really big. Their head, their weight, everything's big, but then they slow down, and then they end up to be relatively normal size. But they have normal growth hormone and IGF-1 levels. Beckwith-Wiedemann, another syndrome. These are the kids that come out kind of look a little like Downs. They got a big tongue. They can have an omphalocele. They can have a hepatosplenomegaly. But they have this beta cell hyperplasia and get hypoglycemic. And you got to get that pancreas out of there, usually. But these kids are also at risk for Wilms and hepatoblastoma. So once you make that diagnosis, you're kind of obligated to follow ultrasounds and alpha-fetoproteins like every 3 to 6 months for 6 years. Because if they get it, it's a very rapid growing tumor. And again, another chromosome mapped to 11p15. We talked about Klinefelters. This is one the slide doesn't work right. But basically, if you have a kid that is morphinoid body habitus, right? Abraham Lincoln, right? Tall and lanky, right? Tall stature, an increased arm span, okay? And big long fingers and toes. That could either be Marfan's or it could be homocystinuria. Okay, so good board question. So Marfan's, it's autosomal dominant. They have a normal IQ. So I always said those lenses, they both have lens problems. With Marfan's, their IQ is up, so their lenses go up, okay? And they have aortic dilatation. And then the homocystinuria side, again, tall and lanky, but they have an inborn error of amino acid metabolism. So they have mental retardation, and since their IQ is down, their lenses go down, okay? So one of the residents taught me that, one of the residents that was way smarter than me. So I said, oh, that's a good way to look at it. So anyway, so that you know those two, the difference between the two. Again, another good board question. Gynecomastia. 16-year-old male presents to your clinic for physically has no complaints of presentation. He's learning difficulties. He's bilateral gynecomastia. He's Tanner 4 pubic hair and 6 cc testes. Okay? So how to make the diagnosis? A drug screen, prolactin, chromosomes, estradiol, or testosterone. Very good. So the answer is chromosomes. Again, when they ask you a question, read it. It's like, why did they tell me this? You know, why did they give me this information? Why did they tell you that he's having learning difficulties at school? You know, and then when you look at the exam, again, the adrenal gland seems to be working fine with the hair, but his testes are kind of small based on that Tanner 4. So he potentially has Klinefelters. So gynecomastia, big problem. Kids don't like it at all. About 2/3 of boys are going to get it. So when you look at gynecomastia, what you got to figure out, is it normal, pubertal stuff, or is it abnormal? Okay? So the normal pubertal, the breasts themselves are not that big. They're like 4 centimeters in diameter. They're kind of like a Tanner 2 breasts. Okay? Their pubic hair and their androgens are by either a Tanner 2, 3, or 4. And if you see that, and the kid's exam is totally normal, then you don't have to do anything. You've made the diagnosis of pubertal gynecomastia. You reassure them and tell them we'll go away in 2 to 3 years. They want to go away yesterday, right? But it's going to take a little while to go away. Then you got to differentiate that between something called macrogynecomastia. Those are big breasts. Those are greater than 4 centimeters. Like Tanner, you've seen them, right? 3, 4, 5 breasts on boys, you know. Those aren't going to go away with time. Because by that time, you've had structure. You have like the fibrous tissues that have formed. So once all the hormone levels get back under control, those breasts are just not going to get smaller. So again, you're going to differentiate who needs labs and who doesn't, okay, by good history and physical. So again, gynecomastia, there's something wrong. There's too much estrogen or not enough testosterone. Again, it's not a set number, but that's what you're trying to figure out. Where are they getting the estrogen, or why don't they have the testosterone? Again, in Klinefelters, aromatase activity is excessive because, again, testosterone goes to estrogen because of the aromatase, right? Galactorrhea. Now, if they have galactorrhea, they have a prolactinoma, so you got to get a prolactin level. Okay, so otherwise you don't have to. If there's no galactorrhea history of it, you don't have to, because prolactin doesn't cause increased breast size; it causes milk development, right? So, and ketoconazole will inhibit testosterone production. So then again, so your gynecomastia, okay, too much estrogen. Where could they be getting the estrogen from? Liver, kidney, and thyroid disease, estrogen is not metabolized normally. Now, that's not going to be their first complaint when they come in, but that's one of the things you have to think about. If you have too many androgens on board, androgens, again, go to estrogen. So that ratio is off. So an adrenal tumor, a testicular tumor, anabolic steroids, androgens, aromatase, estrogen, breasts, okay? This one, an HCG-secreting tumor. HCG has alpha and beta subunits. It looks just like LH. So when your body sees all this HCG, it can go to the LH receptors and start LH, increase testosterone production from the Leydig cells, and then increase estrogen. So an HCG-secreting tumor could be presenting as gynecomastia, okay? Obesity, there's a lot more aromatase, so you get more estrogen made from the testosterone. Again, low testosterone is gonadal failure or Klinefelters. So again, you're evaluating this kid, a good history and physical, a detailed breast exam. These kids think they have breast cancer, okay? They are deadly afraid of breast cancer. And I had one boy come in, oh my God, and so I said, well, does it ever hurt? Is it ever uncomfortable? And this like 15-year-old boy, he's like, well, no, it was only hurt when they did the mammogram on me. And my jaw, like, I was like, I mean, you ladies, I don't know if anyone's old enough to have mammograms. They're not the most comfortable. And if you don't have any tissue, it was all probably pectus muscle on this poor little boy. I'm like, who do you go see? Oh, this poor kid. But anyway, yeah, you don't need to do a mammogram, okay? But they are afraid they have breast cancer. You look for adenopathy, you do a good abdominal exam, and you got to do a testicular exam because there is a little bit of a peak of testicular tumors in teenagers, right? And so gynecomastia could be the presentation of a testicular tumor. Because if you're making too much testosterone, goes to estrogen, you get gynecomastia. So make sure not only are you doing a Tanner stage, but you're doing a good testicular exam on these kids. So who needs abnormal Tanner stage, 1 or 5? Abnormal age, less than 10, older than 16, abnormal pubertal progression, the macrogynecomastia, which will need surgery to go away, or if the kids, even if they don't have macrogynecomastia and they want those things gone and they want to go see a surgeon's not going to touch them until you do hormone levels on them. Okay? So what hormones do you need? Well, obviously we talked about estrogen, testosterone. You want to get LH to rule out an LH secreting tumor, a DHEAS to rule out an adrenal tumor, HCG for a tumor also. So those are the baseline. Any evidence of chronic disease, thyroid, liver, kidney, you want to test those. If not, you don't need to. If you're worried about Klinefelters, again, not big testes, but a lot of hair, you're worried about Klinefelters, you want to get chromosomes. If there's evidence of galactorrhea, you're going to have to get prolactin. I have another funny Katie story. I'm like going off, but I was driving her and her friend down to I don't know, Dave & Buster's, which is a place, and so I was on call, and I got this phone call. It wasn't like diabetes. It was a kid who come in with galactorrhea, and the two of them are like, I'm talking to them about galactorrhea, and they're like, what was that, Mom? And so I said, well, it's when you get breasts and the milk comes out, and she's like, oh, it's kind of like diarrhea of the breast. I was like, I can't think of galactorrhea without thinking of that now, like diarrhea. She's a funny kid. So anyway, if you have, I'm off track here, elevated HCG, then you got to worry about a tumor. You got to look in the testes. If not, you got to look in the chest or the abdominal CT. If the estradiol is high, again, testicular ultrasound, adrenal CT. If the DHEAS is high, you worry about an adrenal tumor, so an adrenal CT. So there's a lot more to gynecomastia than just saying pubertal, okay? So make sure you're looking at them appropriately. SIADH and stuff. So 9-year-old, ICU post-op for cranio. His sodium has fallen. You're concerned about SIADH versus cerebral salt wasting. Which two clinical clues will differentiate the two? SIADH has decreased urine output and high ADH. Cerebral salt wasting has decreased urine output and high ADH. SIADH has increased urine output and is hypovolemic. Cerebral salt wasting has evidence of hypertension, and SIADH has evidence of hypertension. This is a hard one, so do your best there. Oh, very good. So that's the answer. We'll talk about this. SIADH, syndrome of inappropriate, it's not really an endocrine problem, okay? Something's going on. Usually you're sick, you're in the ICU, you have meningitis, pneumonia, encephalitis. This is a good board question. Vincristine and vinblastine can cause it. You're sponge-like, okay? Everything you take in, you are soaking in because of the high levels, the inappropriate high levels of ADH. So as a result, you get this like dilutional, you get hyponatremic, your serum osms are low, and your urine osms are very, very high. So the only thing you can do is to treat the problem, the pneumonias or the meningitis, and fluid restrict them. Because the more fluid you give them, the more they're going to absorb. And the more they absorb, the lower their sodium goes. DI is an endocrine problem. You can have central or peripheral or renal, okay? Now, within the central, it could be inherited forms, this DIDMO, another syndrome, diabetes insipidus, diabetes mellitus, optic atrophy, and deafness. Acquired forms, again, are the more scary ones, the gliomas, the cranio, ID, these are good board questions, sarcoid, histo. Basilar skull fractures can actually cause it. So what we're trying to differentiate is make the diagnosis and then treat the problem too. The thing that should make you scared is that if they would give the diagnosis of idiopathic central DI, that makes me very nervous because germinoma, it initial presentation of germinoma. Like the germinoma hasn't been big enough to see on MRI, but it's causing enough problems to cause DI. So it could take up to 3 years to make that diagnosis. So if I evaluated this kid and I can't figure out why he has DI, he's getting an MRI, an HCG every 3 to 6 months to try and make that diagnosis of a germinoma. Same thing if they said everything looks fine, but their stalk is a little thick. Again, germinoma, and you got to watch very, very carefully. Okay. Nephrogenic, again, you make the ADH, but you don't respond to it. Lithium is a culprit, and sickle cell. Okay, it can be inherited also as far as an X-linked. So DI, these kids they crave water. They drink a lot and they pee a lot, and they crave ice water for some reason. And they'll drink out of the toilet bowl, they'll drink out of the dog dish. I mean, anywhere they can get water, they will drink water. They don't grow well because they just aren't getting any calories because they're filling themselves up with water. And again, on labs, they have hypernatremia and a hyperosmolar serum, but a very dilute urine. So if you're worried about DI, you never want to deprive this. If they truly have DI, you don't want to deprive them of fluid because they can get themselves in trouble. A lot of times they have a good thirst mechanism, and they're able to keep up with their fluid status. How do you make it? You bring them in the hospital, and you do a water deprivation test. I mean, we're like so mean. We don't feed them. We don't give them water, but no water, okay? And then you watch their labs, and you watch their weight. And then when they start getting in trouble, and you think, okay, then you give them ADH, and you see if they respond. So if they respond to it, they have central. If they don't respond, they have nephrogenic. So that was a board question one time. They showed you a bunch of labs, and then at 11 o'clock they gave ADH, and then a bunch of labs, and the labs didn't change. So they had the nephrogenic. They couldn't respond. So if you have central, use DDAVP, and if you have nephrogenic, low-sodium diet, thiazides, or prostaglandin inhibitors. Cerebral salt wasting, another non-endocrine thing, but we'll get involved because it could be other things. But again, low sodiums is how they present. They're sick, and usually the neurosurgeon has messed around with their brain. Okay, so they have a brain tumor, head trauma, surgery. The classic presentation is a subarachnoid hemorrhage. So if it's been some sort of a child abuse, they can present with this. They have lots of urine output, but a low sodium, serum sodium, not because of the dilutional factor like with DI, but, SIADH, but they're losing it in their urine. They have a lot of sodium being lost in their urine. Okay, so differentiate, both SIADH and cerebral salt wasting have low serum sodiums. But with SIADH, as you guys know, sponge-like, so you have decreased urine output. Cerebral salt wasting, increased urine output. Measure their sodium in their urine. It's slightly high, but it's very high with cerebral salt wasting. If you measure ADH, it's high, and then it's low, and atrial natriuretic peptide is normal, and then it's high. But the way you're going to differentiate is to get that urine sodium, and it's very, very high with cerebral salt wasting. Now, the treatment is different. You're going to fluid restrict them with SIADH and treat the cause, but with cerebral salt wasting, you're going to give hot salt, 3% sodium, and maybe some salt supplemental, oral salt supplementation. Easy for me to say. The other thing you can see, hyponatremia with SIADH, cortisol deficiency can cause hyponatremia. Okay, not mineralocorticoid, just cortisol, okay? And they can get hypoglycemia because of the cortisol, but their K is normal because it's not a mineralocorticoid problem, it's just the cortisol. Okay, so another reason for low sodium. Prolactin, one slide. I'm not going to say galactorrhea, right? But anything prolactin negative inhibition. And so you can have, with severe hypothyroid, we just had a kid who came in with a TSH of like 300 and a prolactin of about 150. And they already did a MRI on him. And you didn't necessarily need to do that because you can have very, very high levels of prolactin just because of the TRH and not a prolactinoma. But that's the thing. If you have a high prolactin and the thyroids are normal, you have to worry about a prolactinoma. It's the most common, so always a good board question, anterior pituitary tumor. Amenorrhea, headache, galactorrhea in about 25%. Girls more than boys, and again, you want to do an MRI. So we're going to get through thyroid because we just got to. So Lots of questions on thyroid, lots and lots, okay? 14-year-old, routine physical, normal except for a symmetrical goiter. She has no evidence of hypothyroidism or hyperthyroidism. Appropriate workup, thyroid ultrasound, FSH, free T4, TSH, ultrasound, free T4, TSH antibodies, T3, T4, TSH, thyroglobulin, or thyroid uptake. Let me make sure I push the button. There we go. And we got the right answer. Very good. It is C. Very good. We'll talk about this. Again, symmetrical goiter, free T4, TSH, thyroid antibodies. That's all you need 98% of the time. Okay? No T3, reverse T3, T3RU, free T3, blah, blah, blah. Okay? Free T4, TSH, thyroid antibodies. If you have to order more than that, you better have a really good reason why, okay, because you don't need it, okay? And if it's symmetrical, you don't need an ultrasound. Everyone's all excited. They finally feel a goiter. Oh, I felt a goiter. You know, they do an ultrasound on it. You don't need to. If it's nice and symmetric, you don't need one. It's the nodular one that you need it to rule out the cancers. So TSH, the most sensitive. Good board question. The most common cause of elevated TSH on levothyroxine is noncompliance, okay? Noncompliance, that's usually a lot of answers, right? So free T4, that's the thing you need. The best test for kids, free T4 and TSH. Adults, you really just need the TSH, but for kids, you need both. Now, the thing that messes people up, and I don't know why, it was this total T4. Because total T4 is a measurement of the thyroid binding globulin and the free T4. Excuse me. So if your thyroid binding globulin is falsely elevated, you're going to have a falsely elevated free T4. If thyroid binding globulin is low, you're going to have a falsely low free T4, but total T4. The free T4, though, that portion is normal regardless of where the binding globulin is. And having too much or too little binding globulin isn't a disease, right? You don't want to worry about that. It's the free T4. But, again, birth control pills can make the binding globulin go up, and then your total T4 will go up, but your free T4 is normal. There's a congenital deficiency in thyroid binding globulin where your total T4 will be down, but your free T4 is normal. And that's the one that's physiologic, and that's the one you really only care about. So we'll talk about that a few times. They will ask questions on thyroid binding globulin. When you're imaging somebody, again, you can get an ultrasound. What's that going to tell you? Solid versus cystic, and single versus multiple. 30 to 50%, probably more like 20, 25%, but our nodules are malignant in kids, okay? I think my other slide, I didn't update this one. This should really be about 26% is the number that I read of solitary nodules in kids are malignant. So still about 1 in 4, so that's still a pretty good number. Thyroid scans, that's when you give technetium or iodine, and you're looking to the nodule, is it hot or cold? Again, it results in a picture of the thyroid, and about 30% of the cold nodules are malignant. So another piece of information. This uptake, what it is, and this is going to give you a number, not a picture. You really, I don't really do this very often, but what you're looking for is trying to differentiate hyperthyroidism, reasons for that. Because if you have Graves' disease and you give them radioactive iodine, about 100% is taken up in 6 to 12 hours. So it's just all sucked into the thyroid. So you're going to get a number, 100% in 6 hours. If you have any of these other ones, like subacute thyroiditis or postpartum or whatever, you're only going to get maybe 10 or 15% uptake. So it's the percentage that is sucked into the thyroid after a period of time. And it helps differentiate types of hyperthyroidism. So who's going to need imaging? If you have a nodular goiter, yes. They get images. They get an ultrasound and a scan. If you have a symmetrical hypothyroid goiter, no. Symmetrical euthyroid goiter, no. Symmetrical hyperthyroid, majority of the time, no. But the only time you would do it if you want to differentiate Graves' disease. Okay, so the chart here just sort of puts it in a chart form. So you have the kid coming in with a symmetrical goiter, and clinically they're either hypo, hyper, or euthyroid. Everyone gets a free T4. Everyone gets a TSH. Everyone gets the thyroid antibodies, the thyroglobulin, the PTO. The only ones that are going to get this TSI, the thyroid-stimulating immunoglobulin, that's the Graves antibody, is the hyperthyroid kids, okay? So again, as I said, 98%, you get the free T4, TSH, and thyroid antibodies, and that's going to give you the answer. You don't have, if they're hypothyroid, no imaging, euthyroid, no imaging. Hyperthyroid, again, small, I think I've ordered it 5 times since 1990, okay, that you would get that to differentiate Graves from other forms. So that binding globulin we talked about, increased thyroid binding globulin will falsely increase the total T4, and then you say, oh my God, they're hyperthyroid, but they look sluggish like, it's like treat the patient, you get these labs on them and it doesn't make any sense. And then you say, okay, why is the total T4? Are they pregnant or are they in birth control pills? Because that will cause it to be falsely elevated. Other things can cause it, narcotics, biliary cirrhosis, but the most common one, the good board question, is the birth control pills. So their total T4 is up, but their free T4 is normal. Decreased thyroid binding globulin will falsely decrease the total T4. Most common one is TBG deficiency. And you'll find that out on the newborn screen. We'll talk more about that later. But the free T4 is normal. So please understand thyroid binding globulin because you will see that on the boards. So again, 2 common scenarios. A baby with thyroid binding globulin deficiency will fail the newborn screen because that's the only time you have total T4s is in the newborn screen. Okay, but the total T4 is low, but the free T4 is normal and the TSH is normal. And a girl on birth control pills is going to get a falsely high total T4 because of their birth control pills and the increase in the TBG. So total T4 is elevated, free T4 is normal, and a normal TSH. So those are 2 really good board questions right there. So Hashimoto is the most common cause of a goiter in a kid greater than 6. And basically, it affects about 1 in 600. And their thyroid is usually big, and they have like this lymphocytic infiltration of it. So if you were to do a biopsy on it, it would be, there'd be a bunch of lymphocytes in it. So sometimes they call it chronic lymphocytic thyroiditis. That's the same thing as Hashimoto's. Okay, so don't get caught up in that. Not as common anymore, but just in case. But again, with Hashimoto's, you can be hypo, hyper, or euthyroid. In order to make the diagnosis of Hashimoto's, you just need positive antibodies, 1 or all 3. So that gives you the definition of Hashimoto's. So there's 4 possible clinical scenarios. You can be frankly hypothyroid with a low free T4 and a high TSH. You can have compensated hypothyroidism with a normal free T4 and a high TSH. You can be hyperthyroid with a high free T4, low TSH, and then you can be euthyroid. So those are the scenarios that you can possibly have. So free T4, TSH is all you need. So again, management, nice and symmetrical, no need for imaging. If they're hypothyroid or compensated hypothyroidism with just the high TSH, just treat them with Synthroid. The euthyroid kids, the board question they like to ask is that you have to follow them every 6 months because they can flip. They usually flip from euthyroid to hypothyroid, especially during the adolescent years. So you want to follow their labs every 6 months. Sometimes, these kids with the big goiters, they don't like their goiter. Teenage girls, they come in, it's like 90 degrees out, and they have a turtleneck on because they don't want anyone to see their neck. And they want that to get smaller. And because if it's the lymphocytes that are infiltrating it, it's just time maybe is going to make it smaller. Some people have tried to use Synthroid to decrease the size of it. It doesn't really work, okay? Only if you need it. If you need Synthroid, you need it, but not these euthyroid kids. It's not going to help. And then the hyperthyroid kids you treat just like you would Graves' disease with propranolol for the symptoms and then methimazole. PTU is no longer recommended in kids, okay? Used to be great, but no longer because of the risk of liver cancer. Okay, so that's a good board question there. And then you got to wait five half-lives or 5 to 6 weeks for the TSH response. TSH I kind of think of like a hemoglobin A1C. It's like 6 weeks prior to what's been going on. Okay, and so again, I'm taking my medicine. Like why is your TSH always high? And so these are the good board question. Okay, good clinical question. Patients that have abnormal TFTs and they're on Synthroid, they're non-compliant. So there are 2 sort of scenarios. One of them is that they have normal free T4 and a high TSH. They just have never kind of closed that loop during those 6 weeks because they haven't taken their medicine. So they're not as smart as these kids. These kids, like, they haven't taken their thyroid medicine for a while, and then they say, oh, I got to see Dr. Pfeiffer in a week. And then they, like, triple their dose for the week, okay? So they can get your free T4 up to a normal range by doing that, but the TSH has a 5-week lag time, so that's not going to be suppressed. So those kids will have a high elevated free T4 and TSH because they haven't been taking it for a few weeks, and then they took a bunch of it, okay? So anyway, 2 good board questions. Subacute thyroiditis is a viral infection, and they go through cycles. The big thing about that is that their thyroid hurts. It's painful. It may be a little bit red, and they've had cold symptoms. And so if you get that sort of scenario, you want to get a SED rate because their SED rate is really very high. The reason you want to follow this is because they'll go through these cycles. They'll be hypo, and then they'll be hyper, and then they'll be euthyroid, and they can change over every month. So you want to sort of follow them more closely. This central hypothyroidism, there's something wrong with their brain. The obvious one to me is like the low free T4 and the low TSH, right? That's obvious, right? But if you have a low free T4 but a normal TSH, that's also central hypothyroid. Because your free T4 is low, what should your TSH be? It should be sky high, right? So your TSH is inappropriately normal for your free T4. So again, if you only got a TSH on that kid, you would miss it. Okay? So low free T4, normal TSH is central hypothyroidism. So that's why you want to get both. Okay? So think about that one for a while. But the residents sometimes say, oh, yeah, that's right. They think about it. Okay? Graves' disease, other side, too much, hyper, okay, TSI, thyroid stimulating immunoglobulin. It's not the thyroid antibody. If you get the thyroid antibody, you're going to get the PTO and the thyroglobulin. But the TSI is specifically what you want to get. They can also have thyroglobulin peroxidase, but they're the ones who have the positive TSI. And again, you have to specifically ask for that. Again, they're on the other end. Their TSH is low and their thyroid levels are up, okay? Signs and symptoms, anxiety, increased appetite, weight loss. Some actually have weight gain because they're eating so much. But, they are just shaky, sweaty. They just read the book, these kids, okay? Poor school performance. And then they'll have a goiter and tachycardia. The thyroid and the heart, especially the heart rate, go along. So if I look at the heart rate, that usually is a good indication of what's going on with the thyroid, okay? They don't get some of them get exophthalmos, but usually their eye disease is not that bad. The one thing I want to tell you is that if you have a big thyroid, listen to it. Okay, because if you hear a bruit, there's a lot of blood flow through that, and about half the time they're going to be hyperthyroid. So take your stethoscope out and listen to it, okay? Their eye disease tends to be more just injected eyes, like allergic eyes. I've never had to treat their eyes. Adults, a lot of times their eye disease is so severe that they're using steroids or radiation or something, surgery. But kids, it's usually just, you want to make sure that they can close their eyes at night. Because if they can't, they can get really dry eyes, and then they can rub their eyes and get like corneal abrasion. So sometimes you have to use like eye drops or, some sort of something on their eyes just to keep them moist so they don't get corneal abrasions. So 3 choices: medicine, surgery, or radiation. So usually people start off with medicine. PT or methimazole. They both block thyroid production. I used to like P2 because it also blocked T4 to T3. And T3 is your more active one, but we can't use P2 anymore because it causes liver cancer. So we just have methimazole, which is still good. So you use methimazole, but you also use beta blockers like propranolol to help with the shakes and some of the symptoms. And so until it takes your thyroid levels get back into normal range, they're often on the Inderal. And that's usually about a month to 2 months or so. What you want to do is you're on this for a very long time, and you want to sort of quiet the thyroid down and then wean them off of it because they can't be on the medicine for the rest of their lives. But as they wean off of it, but about half of them are potentially going to relapse. And it's kind of a funny thing. It's that TSI. I mean, if you can suck that out of them, that would do the treatment, right? But you don't. So that can kind of go up and down. I'm not quite sure why, but if they're on a downslope, you can take them off the medicine and see how they do. And half of them will relapse and half of them won't, okay? what do I want to say? So, and then sometimes the likelihood of remission, we don't really know who will, but if they have a huge thyroid and it gets smaller, they're going to probably stay, they're going to have a good remission. They're not going to relapse. And if the antibodies, the TSI starts falling down, they probably will not relapse either. So those are two good indications of who's not going to relapse. Side effects are very important. The most common are rash and granulocytopenia, but the most serious is this agranulocytosis. Those are kind of like the kids, the chemo kids, up on the hemonc floor, where you treat them and they have no white cells left. What do? They get the stomatitis and they get the bad throat. So what you want to ask them, if they start having fever, sore throats, and mouth sores, usually within the first 3 months of starting it, they have to come to the ER or someplace immediately to be looked at to make sure that their white cells are okay. Obviously, you'd have to stop the medicine at that point and try something else. And the other else is this radiation. It's an oral administration of iodine-131. What you're trying to do is kill off the thyroid just enough that they're not hyper, but they're not hypo, because they don't have to be on Synthroid all the time. Usually, they end up being on Synthroid, okay? People get a little nervous. Radiation, oh my gosh, I'm going to glow in the dark, blah, blah, blah. But it's been around, if you're 30, 40, 50 years of age, it has a 50-year safety to date, so that's fine. You're an adult. When you're a 3-year-old kid, that's kind of asking a lot. So usually it's the teenagers that will do this for. If a little kid needs something besides medicine, they get this thyroidectomy, okay? So these are the kids that have failed medical treatment, they relapse, they have a huge goiter, or they're very young, or they don't want radiation. You don't want like the first guy to say, oh, I'll do the thyroidectomy. They need experience, okay? It's very complicated. You got the recurrent laryngeal nerve in there, the parathyroids. It's very vascular. So you want somebody with good experience to do this surgery because of complications. Again, hypopara, recurrent laryngeal nerve damage, and then the permanent hypothyroidism. Not very common, but, it does happen. But I think the important thing that you guys know are the complications of it. Neonatal Graves, this is very rare but very scary because mortality is about 25%. Remember, we talked about that TSI, the thyroid-stimulating immunoglobulin. It never goes away. So mom has Graves, even though she's had radiation, she had surgery, she still has that TSI. Just like any other antibodies, it can cross over to the baby. So again, relatively rare, 1 in 1,000, and only 1 in 70 have this, but mortality is 25%. So what are you looking for? This history of mom, and so, again, the TSI is the important thing. There was a board question one time about good control of the mom's thyroid function test. Is the baby at risk for Graves? Well, normal TFTs doesn't tell you anything about the TSI. So it's the TSI, not mom's TFTs, that are the important thing, okay? These babies, just like any other person with Graves, they're shaky, they're sweaty, they're irritable, they don't eat right, they don't gain weight. And the scary part is it's going to happen in between discharge and coming in for the 2-week well baby check. Okay? So again, never go away. The question you got to ask is if, you find out the mom's on Synthroid, why is she on Synthroid? Does she have Hashimoto's? Or does she have Graves' disease and her thyroid was ablated? Because that would make you want to watch that kid a little closer. So you treat just like you would treat somebody with Graves with methimazole and propranolol. The nice thing is that once all the antibodies go away, the Graves goes away, and this kid's at no more increased risk for getting Graves' disease in the future. Thyroid cancer, malignancy, 26% of the time. Hard, not, greater than 1 centimeter, radiation to the head or neck, a big nodule that's firm or hard if they're hoarse, or this family history of MEN, which we'll talk about. I've seen a few cases of it, and a lot of them that had a bunch of lymph nodes, and they were treated kind of inappropriately as cervical adenitis. Okay, so make sure if you have a kid with a bunch of nodes, which is very common, lymph nodes, make sure you're feeling the thyroid as best you can. I know it's a difficult exam, even for me, but you just have to at least document that you tried, and there's no family history or any risk factors, okay? The MENs, you got to know this, okay? There's MEN 2A and 2B. 2A, the medullary thyroid carcinoma, the hyperpara, and the PHEOs. Again, get out one of those 3x5 cards. It's autosomal dominant, and the nice thing is that you can look for these a specific oncogene, and you can test for that. And if they have a specific oncogene, it puts them more at risk for getting the medullary carcinoma. So I have this one family that I follow, and the mom had it, the little 4-year-old has it, and the little baby has it. So we know when that kid turns 5, you're going to have to take out the thyroid because of their risk, because they have that specific oncogene in their genetic disposition. Okay? The MEN2Bs, autosomal dominant, they also have medullary in the pheo, but they have the ganglioneuromas, all the little marks around their mouth and lips, and they have the marfanoid habitus. So that's what makes them a little bit different. Again, you can measure, look for the red oncogene, specific oncogenes. The big difference, by 6 months, you got to get their thyroid out because their medullary carcinoma can occur really early and be very aggressive. So the 2As is by 5, and the 2Bs are by 6 months, okay? Again, nodules equals imaging. Ultrasound hot versus cold, ultrasound solid versus cystic. Scan hot versus cold. A lot of board questions on this, and the way they ask it is, what's the most definitive test? Stick a needle in it, okay? So a fine needle. It's not the first test you're going to go to, but because the ultrasound, solid versus cystic, but it's not definitive. Hot versus cold, not definitive. You stick a needle in it. Do we do that clinically? Usually we get the whole thyroid out by a surgeon, but anyway, the board likes this question. So the most definitive test for a nodule is to do a fine needle aspirate. Usually if you don't know the answer in something, you do the least invasive. You know, if you're not quite sure. This is very invasive, okay? So that breaks that rule. So stick a needle in it, okay? You know, there are a lot of structures that you could potentially hit, okay? So, but that's the most definitive, and that's the board question answer. Binding globulin deficiency, we talked about this again. The newborn screen, you're going to get a phone call. This kid failed the newborn screen. They're going to have a low T4, total T4, and a normal TSH. That could be binding globulin deficiency. It was like 1 in 8,000, or central hypothyroidism, which is like 1 in 100,000. How do you differentiate the two? By getting, this is the only time I get a total T4. You bring them in, the TBG deficiency, a low total, a normal free, and a normal TSH. Central hypothyroidism, low total T4, low free T4, and a normal to low TSH. Okay? So you can also measure binding globulins, thyroid binding globulins, and measure it. But this is important to identify because, you know, again, they don't need medicine. And they just need to be followed with free T4s, not total T4s. I think one of the last thyroid things. Congenital hypothyroidism, preemies get it. Full terms, the most common is the dysgenesis. So that's the ectopic, the agenesis or the dysgenesis. This thyroid hormone, dyshomogenesis. Make a thyroid, you need to have the MITs and the, so the iodinate, the tyrosine, then you got the MIT and the DIT, and you put them together, you make T3, T4. It's about 8 steps there. So if there's a problem with one of those steps, that's the dyshomogenesis. Panhypopit, 1 in 1,000. The transient, 1 in 40. Most common worldwide is iodine deficiency. So thing about evaluation, I mean, there come classic signs, but the most important thing, it's a progressive disease. So only less than 5% are going to be diagnosed on exam. But at 4 to 6 weeks, if you haven't caught it, they're going to progress and get, you know, just very coarse looking, almost like a, obviously a genetic problem, like a glycogen storage disease, just that coarse sort of look. Macroglossia, horse cry, distended abdomen, the hypotonia. But again, it's a progressive disease. So you want to start ASAP. They call you on Friday. You got to see that kid on Friday because the time is wasting. And the longer you wait to treat, the less IQ points they're going to have. Okay. So again, they come in. It's the only time I get a total T4, free T4, total T4, TSH. Get out your Harriet Lane. That's what I use because that's what it comes right out of the endocrine text. Okay. Scanning, pretty controversial. I don't think none of my partners do, but you want to know the endocrinologist that you work with, whether or not they're going to want to scan. And a bone age. Bone age is delayed, then they're more severe potentially. Got to start promptly, again, hopefully within the first 2 weeks. The biggest thing, like you send them home and they're pills. There's no suspension. So the mom's like, how am I going to get this into my kid? So you got to teach them how to, they have to crush it up, and they got to put it either in water or breast milk, not soy, because it will interfere with the absorption. Okay? And they got to give it every day. That's the important things. And hopefully they'll develop normally. There's still some problems. They do have some LD in math and problem solving. 20% there's a neurosensory hearing deficit associated with it, so you'd be quick to screen. Doesn't say you have to do hearing tests. They get them anyway. But look for that. But they're losing IQ points if treated after 2 weeks. Okay? Thyroglossal duct cyst, that's the thing in the middle of the neck and goes up and down. It forms when the track is left during descent of the thyroid from the base of the tongue. And most of the time it's not a bother. A lot of times it'll get infected. And it gets infected, and then and they say, I don't want this thing anymore. I want to take it out. So you send them to a surgeon. What's the surgeon going to do? Take it out, right? And then, a few months later they come to see you, and they're not growing well, and they're gaining weight, and they're constipated. You're like, oh, boy. So you want to make sure that when they take out that cyst, it's not the only functioning thyroid tissue that they have, because your counseling is going to be different. Okay, well, you don't want to take medicine every 2 weeks for a few years because it keeps getting infected. If we take that out, we're taking out all your thyroid tissue, and you're going to be on medicine every day. So just to help with, pre-surgical counseling. And the small percentage of them will have thyroid in there. Most of them have normal thyroid tissue, but again, something you want to test for. So that's an indication to get a scan to make sure that their thyroid tissue is normal and not all just in that cyst. So everyone always gets worried about calcium, and the calcium questions are always like a volume, right? It's like, oh my gosh, look how long this question is. They all look like this. And you're like, I'm running out of time. I don't even understand calcium. I hate calcium. I'm just going to guess. So I'm going to give you the tools to get through these questions, okay? So let's read through this. 12-month-old African-American male presents to the clinic for a 12-month-old baby check, exclusively breastfed. Again, look for the clues. You plot his growth. You notice his height has decreased from the 50th to less than the 5th. The rest of his growth percentiles are stable. You recheck the length, and it's correct. Your workup includes a calcium that is low, a phosphorus that is low, a PTH that is high, and an alk phos that is high. Okay? So most likely hypophosphatemic rickets, vitamin D deficient rickets, pseudohypopara, vitamin D resistant rickets, or hyperparathyroidism. So I'll let you guys answer that. Oh, very good. So you guys know it. Vitamin D deficient rickets. Good job. Because this is really, again, this is truly really all you need to know in this slide. If both the calcium and the phosphorus levels are too high, they have too much vitamin D. If both the calcium and phosphorus levels are low, they have too little vitamin D. If the calcium is high and the phosphorus is low, they have hyperpara. When calcium is low, the phosphorus high is hypopara. Okay? That's all you need to know. I had a chief resident one time. It's the last questions on the board. You know those 5 questions you got to. And he's sitting there, one up, one down, trying to figure it out, and everyone else is sweating or giving up. And so, but Rich answered all those questions appropriately, and that's really, to be honest with you, all that you need to know for this, okay? And that's because of the physiology of calcium and phosphorus metabolism. If you look on this side, it's complicated because there are different organs. You know, you got the gut and the bone and the kidney, and then there are also different hormones. So the calcium side, the parathyroid and the 125 vitamin D work at the bone and increase it. They also, parathyroid 125 vitamin D at the kidney, increase it, and also at the gut. Now, at the other side, you got the phosphorus. Same thing at the bone. You got the parathyroid and the 125 vitamin D to increase. 125 vitamin D to increase it at the gut. This is the negative, okay? This is the teeter-totter. The parathyroid and the PTH, parathyroid hormone will decrease phosphorus and increase calcium. And that's the teeter-totter there. So that's why one will go up and one will go down, depending on, again, if you're hypo or hyperparathyroid. The other thing that's important with vitamin D metabolism and calcium and phosphorus is vitamin D metabolism. So starts off as cholesterol. This is your skin, okay? It's not a river. This is your skin, okay? I'm not an artist, okay? So then you got the sunlight, okay? 80% of your vitamin D comes from sunlight, and it doesn't, it takes like 10 or 15 minutes, okay? And so you're out there, you get some good sun, and then put on your sunscreen, okay? But you go to pre-vitamin D, vitamin D3, and then you 25 hydroxylate it, and that's not a pond, that's your liver. I couldn't find a liver. So that's your liver. So that's where so if you have liver problems, or if you're on anti-epileptic medicine, you're going to have trouble with this 25 hydroxylate. And then you go to the kidney, and then you 1-hydroxylate it to get the 125, which is the most active. Okay. So vitamin D, you need good sunlight and skin. The liver has to be healthy, and the kidney has to be healthy in order for your vitamin D to work. So rickets is it's relatively rare. It's a disease of the growth plate, so it's only going to happen in kids, right? Adults don't get rickets. So there's something wrong with the calcium and the phosphorus and the vitamin D. It's going to lead to a secondary hyperparathyroidism, except for the hypophosphatemic rickets. We'll talk about that in a minute, okay? So the history, they're irritable, they're weak, they can get fractures, they don't grow well, okay? They get the big frontal bossing, they get this huge forehead, okay? The rachitic rosary, that's along the sternum as the ribs attach to it. If you get problems at the growth plate, which will be at the end, they get these huge knots right there. And that's where you get the rachitic rosary. Their wrists, because again, it's a disease of the growth plate and there's so much activity there, they'll have huge wrists. I mean, you'll have like skinny little arms and then these huge wrists, okay? And you can, then obviously you're going to get an x-ray to see what's going on. The older kids, they can get the kind of the bowed legs. But the important thing with rickets, you have to have abnormal labs and an abnormal x-ray. I mean, I'll get some kids sent to us and the ALK-Phos is like, I don't know, 3,000. But their bones are normal. They have no evidence. It's not rickets. I don't know what it is, but it's not rickets. Not my problem, So, so it's not. But you have to have abnormal labs and abnormal X-ray. So this is a very busy slide. But what I want you to look at, these are the types of rickets. You got the vitamin D deficient. You got the hypophosphatemic. The problem with the 25, the 1-alpha, or if you're resistant to the 125. So if you notice, there's something wrong with your calcium, something wrong with your phosphate. They all have high ALK-Phoses, okay? So that will make the laboratory diagnosis. If you get calcium phos and ALK-Phos, and you also do an X-ray, you're going to get your diagnosis. Then you do the etiologies, okay? The 25, you can get the 125 and the parathyroid. So I'm going to show you this familial hypophosphatemic rickets. We'll talk about that. Their problem is in their phosphorus. They cannot reabsorb phosphorus at the kidney. There's nothing wrong with their calcium, but their phosphorus is really low, okay? And their ALK-Phos is normal. So what stimulates PTH is low calcium, right? There's nothing wrong with their calcium, so their PTH is normal, okay? So that's how you differentiate that one. So again, you got the abnormal labs, abnormal X-rays. They get these huge, they can get this loss of provisional zone of calcification, which are these kind of white lines, and they get cupping and fraying. They get this moth-eaten sort of scalloped wrists, okay? And again, they're huge. They can be at the wrist, at the knee, anywhere there's a growth plate. The rachitic rosary, at the sternum here and the ribs. So that's, sometimes you kind of stumble on the diagnosis. You get a bone age, and the radiologist has to say, oh, I think it's rickets. And you're like, I knew that. I know it's rickets, So anyway, so that's what you got to do. Abnormal labs, abnormal X-ray. The two ones you got to know, vitamin D deficient rickets and hypophosphatemic. The vitamin D deficient rickets, the nice thing about this, it's a transient sort of a problem. It's a kid that has trouble making vitamin D. And remember, the sunlight makes like 90% of your vitamin D. So if this is a dark-skinned kid in the winter, not a lot of light, if they're exclusively breastfed in the first 6 months, and again, the breastfeeding is good, doesn't have a lot of vitamin D in it. So the mom has to make sure that she is supplemented, and we're trying to avoid this thing by supplementing the babies, again, who are breastfed with vitamin D. But again, they have vitamin D, so everything's low. Low calcium, low phosphorus, but their ALK-Phos is high and their PTH is high. And so what do? You treat them with vitamin D, okay? And this is a weird, I always have to check the concentration. It's 8,000 international units per ml, or 200 per drop. So RDA is 400. It's probably going to go to 800, per day. But these kids need like 3,000 a day. And so you treat them until they're healed, and then they're done. I mean, it's, again, a transient sort of a problem. Then once they're healed, they just go back to the recommended daily allowance. So that's kind of nice because it's usually you pick it up usually around 12 months, and by 18 months to 2 years, they're done. Okay? As opposed to this one, hypophosphatemic rickets, this is a tough one. And this is actually, it's the most common in North America. It's X-linked. It can also be autosomal dominant recessive. But the most important thing when they're giving you this history, if they start talking about an uncle or a father that's like bow-legged, or so just be very wary of the bow-legged short grandfather in the story, okay? Because they're making you want to think about hypophosphatemic rickets, okay? So again, as we talked about, the problem is in their kidney, they're losing all this phosphorus, and they're not able to regain it. They're not able to reabsorb it. The calcitriol, which is the 125 vitamin D, is normal, which is fine. Usually your body has these defense mechanisms because think if your calcitriol was a little bit higher, you can reabsorb more phosphorus in the gut. So your body doesn't do that, so we have to do that when we treat them. Again, we talked about the PTH is normal because there's nothing wrong with their calcium, so the PTH is normal. So the calcium is normal, the phosphorus is low, and the alk phos is a little bit high. So how do you treat them? Well, they're missing phosphorus, give them phosphorus. Well, the problem with phosphorus, it's 4 to 6 times a day. You can't even make people take it twice a day, let alone once a day. And it's nasty. It's like Alka-Seltzer. It's all fizzy and ugh. And so they take some, and then they got to do it 4 to 6 times a day for the rest of their lives. So obviously compliance is a problem. But you also use calcitriol because you're trying to maximize the amount of phosphorus that's being absorbed. But be careful with calcitriol. Again, that's the 125. It's very potent vitamin D. So if you're absorbing calcium in the urine, you can get kidney stones. So when you watch these kids, you do the alk phos, the calcium, the phosphorus, and x-rays, but you also do urine calcium and creatinine to make sure you're not giving them kidney stones. Signs and symptoms of hypocalcemia, seizures, tetany, muscle cramping, the paresthesias, especially around the mouth. The kids that have had thyroid surgery, and they played around with their parathyroids, if they start having numbing and tingling around their lips, we get a little worried, okay? The spastic sign is the facial stimulation of the facial nerve, and the trousseau's with the blood pressure cuff. Again, always know EKG changes. It's the prolonged QT interval. Hypocalcemia in the neonate, they break it up into early and late, before and after 72 hours. If it's the before 72 hours, it's usually transient, usually due to the birth or the pregnancy. Good board question, prematurity is the most common cause. Okay. The other things are like all the questions I always answer in the nursery, right? Toxemia, diabetes, sepsis, asphyxia, the same 10 problems they have in the nursery, right? That tends to cause, the before 72-hour hypocalcemia. Again, usually a transient problem. If they do fine and after 72 hours they start getting the hypocalcemia, it's probably more of a chronic problem that they're going to need medicine forever, like parathyroid resistance, maybe DiGeorge, problems with vitamin D. So before and after 72 hours, good board question right there. DiGeorge, we talk about, it's chromosome 22, the catch-22, right? It's a problem with the 3rd and 4th pharyngeal pouches, and the catch-22 is organized in their features, the cardiac disease, the abnormal facies, the thymus, with potentially the hypoparathyroidism, with the problems with your immune system. They can have cleft palate and then the hypopara. They also have developmental problems and an increased risk of psychosis and schizophrenia. But again, another good board question, another syndrome you should be taking notes and getting your 3x5 card out. Hypomagnesium, if you have a kid who comes in and they're hypocalcemic or they have a seizure, what do you always get? Calcium phos mag, right? Like, why do you get that? Well, you get that, the mag especially, Because if you don't have magnesium on board, your parathyroid doesn't work right. So then the parathyroid doesn't work right, and they have a seizure because they're hypocalcemic. So you load them up with calcium, and all is good to go, and you go back to bed, and a few hours later, they're waking you up because they're having another seizure. So you've got to fix the magnesium. You can give them calcium, but if you don't fix the magnesium, and that's the problem, they're going to keep seizing from low calcium. So make sure you're checking the magnesium and fixing it if that's the cause of their their functional hypoparathyroidism. This APS1, autoimmune polyglandular disease type 1, autosomal recessive. A lot of people get this mixed up with MEN, okay? This is, MEN is the cancer one, and the APS is the autoimmune one. And what they usually get, they get total body candidiasis first. They get the hypopara, and then the Addisons. I've seen one in my life, okay? That means it's probably a very good board question, right? It's very rare. Alopecia, hepatitis, diabetes, vitiligo, and another gene that they found, a marker, the ARI gene, is a mutation with these guys. Hypercalcemia. You can be asymptomatic. This familial hypocalciuric, so low calcium in the urine, high calcium in the serum, that's usually, again, you're doing labs and they get a high calcium. You're like, oh, that's funny. They don't have any symptoms. You do it again, they have a high calcium. Then they probably have that, and you want to check the labs in the mom and the dad. It's like a problem with their calcium sensor, and they're just asymptomatic. They just have high calciums, and nothing you need to do about it except to monitor it. But the symptoms that you get, remember that from medical school, the stones, moans, and groans, and the psychological overtone. So they get bone pain, they can get kidney problems, they get anorexia and belly problems, and they can have the, problems with confusion, okay? Now, kids don't get high calcium a lot. Adults do, right? And you think, oh, my God, they have cancer, Kids, it's pretty rare. The most common reason for kids to have high calcium would be the immobilization. So the kids in the total body cast that are sitting there, and again, they have the good board question where they're irritable and they're wetting the bed and they're constipated, and so it's the calcium. They're hypercalcemic. Again, we talked about hyperpara with the MEN1 and the MEN2. That familial hypocalciuric hypercalcemia, it's a problem with the sensor. It's again, you get a lab on them, their calcium's high. You get a lab again, the calcium's high. Mom and dad have high calciums. Nobody has symptoms. Nothing you need to do about it except to document it. Sarcoid or TB can cause it, high calcium, because of the activation of vitamin D. Malignancy is rare, okay, but something you have to think about. Okay, so that is calcium. On to CAH, another very popular one. I heard the... You call to the nursery to evaluate a baby with ambiguous genitalia. The baby has clitoromegaly and a fused perineum. There are no palpable gonads, okay? The baby's exam is otherwise normal except for hypertension. The most likely, salt losing 21, non-salt losing 21, 3 beta, 11, or 23. So you can put your answer in. Okay. Okay, I have a little work to do. Again, I said 21 is probably the best answer if you don't know because that's the most common, but in this case it's 11. What? Okay. Okay, so no tomatoes, okay. See, I think like the hem-onc and all the cascades for the clotting factors is worse than this, personally. But again, I feel like, I'm not sure. The big picture, don't get caught up in the little, just the big picture, okay? So you're looking at this. What do we got? We got the salt hormones, the sugar hormones, and the pubertal hormones, okay? So what does your body live for? Cortisol. If there's something wrong with your cortisol, goes up, tells your body ACTH is increased, and then things get moved along. So if there's a blockage someplace, things are pushed over to the right. So if it's at 21, they're blocked here. You get, if you're a salt loser, nothing blocked, nothing goes down the salt, nothing goes down here, and everything's pushed over. So no salt, no sugar, but all the pubertal hormones, right? The 11, which was the answer, there's a block here. It's right below it. So there's a block here. Deoxycorticosterone, DOAC. Very potent mineralocorticoid. So right prior to that block, you get a lot of this DOAC, which causes hypertension. So you get hypertension, everything pushed over to the right, and puberty. So it's a great board question. Hypertension and ambiguous genitalia is 11. Will you ever see it? No, but it's a great board question, okay? Most common, again, is the 21, okay? And I'll show this picture to the parents, and I say it's kind of like dominoes, you know. One comes from the other, and if you have a blockage, you know, I always say you need like a third, a third, a third, but if there's a block, things are sort of pushed over to the right, okay? So don't get caught up, and just remember kind of how it's set up. And I think that's all you're going to need to know for that, the big picture, okay? So 21 is the most common, okay? And with 21, you can have, we're talking about a complete block, right, at birth. You can have, most of them are going to be the salt wasters, so the mineralocorticoids and the glucocorticoid axis is shot. And 25% are going to be the non-salt wasters, which is just the glucocorticoids, the cortisol. So again, everything's pushed over to the right. So a female is going to be ambiguous because they got all these androgens on board. So the fascinating part is the males, they're not like more virilized. They look totally normal. Even though they have all these androgens on board, they're not hairy, you know, there's nothing going on, okay? So they're just sitting there, and the only way they're going to be diagnosed is if in 2 weeks they come in an adrenal crisis. Because they're going to look fine, but they're going to go home, and they're going to come in shock in 2 weeks, okay? The non-salt loser, they're not going to go into shock, but eventually they're going to have enough androgens on board that they're going to get early pubic hair development. So this is what the state screen is trying to avoid, okay, trying to treat. I have not seen a state screen that has been helpful yet, okay, but I don't know if anyone has. Because usually if you are truly have a block, your 17-OHP, which is the right behind, above the block, is like 60,000, 80,000. And we get consults for levels of 52 when the normal should be 49. So it's just amazing. It's outside the norm, so they come see you. But you know, that's what the state screen is trying to test for, is the boys. Okay. So again, you can have with 21 hydroxylase deficiency the classic salt losers, which is the most common, the classic non-salt losers, which is again the classic meaning at birth, complete block. That's the problem. They have like a million names for like the same thing. I do it all the time in endocrine. So classic meaning complete block non-salt losers. On the non-classic, the partial, the late onset, these are the kids that come in at 9, 8, 9, 10 with like lots of pubic hair and lots of androgens. They just have a partial block. And again, it depends on the degree of these enzymes of the 21 hydroxylase genes. There's a CYP21A and B. And B is the active and A is the pseudogene. And there's this recombination and these mutations, and resulting in point mutations in the active, the 21, the CYP21. And depends on what mutations there are, you're going to either have the classic salt loser, non-salt loser, or the late onsets. Again, early diagnosis is possible if you want to look for 21 hydroxylase deficiency. You can do choriovilus sampling at 10 weeks or an amnio at 18 weeks. You can also do the newborn screen for 17-hydroxyprogesterone. If you're going to treat the baby, if you think the baby has CAH, you're going to treat them, if it's a girl, to prevent the ambiguity. Okay? How do you treat them? Well, if you used hydrocortisone or prednisone, trying to use that as a steroid, it's going to be blocked by the placenta. It's going to break it down. But the dexamethasone, it can't be inactivated by the placenta, and that will get to the baby. So you have to use dexamethasone to treat the baby. If you use any other steroids, it's going to be blocked, and the baby won't see it. Okay. So again, this is just a chart of it, so just a review. You got 21 hydroxylates, the salt waster. Okay, both axes are on. At birth, if it's a female, they're going to be ambiguous. Everything's pushed over to the right. They get all the androgens. They don't get a lot of mineralocorticoids or glucocorticoids. The male is going to be normal at birth. But within 2 weeks, that baby, if it's a a salt waster, that boy is going to come in shock because he has no cortisol. And then his sodium is going to be low, his potassium is going to be high because of the lack of mineralocorticoids. The non-salt loser, again, complete block, female, is going to be ambiguous. Everything's still pushed over to the right. They get too many androgens. The male is going to be normal. But by 6 months or so, there's going to be enough androgens on board in that male that he's going to start getting pubic hair at a very early age. Again, his testes are going to be prepubertal, less than an inch, 2.5 centimeters, whatever, because it's not a testicular disease. It's an adrenal disease, right? So, again, the salt losers, every axis is out, so they have low sodium, high potassium because there's no aldo. They get hypoglycemia because of the cortisol. Their renin is high. 17-OHP is high. Their aldo is low. Elevated androgens. Everything's pushed over to the right. The non-salt losers, they're just missing the cortisol, and 17-OHP is high, but there's no problems with sodium or potassium, okay, because they're fine. Come in with an adrenal crisis, what do? You got to give them fluids, and you got to give them Solucortef. There was a question I was one time, do you give aldo? You don't need to give aldo, which is a mineralocorticoid, because Solucortef has enough mineralocorticoid activity. That's all you need is Solucortef. This cortisone acetate is an older medicine. It's not supposed to be used anymore. It doesn't get absorbed as well. And again, sometimes you're going to have to, their glucose could be really low, so you're going to have to give them glucose. The hydrocortisone will often treat the sodium and potassium, but sometimes the potassium is so high that you have to actually use an insulin drip to get the potassium back to where it needs to go. Again, the newborn screen, only about 39 states do it, so not all of you guys do it. It's a 17-OHP, and we're looking for the male that we're going to miss because they're not ambiguous. And again, this is a picture of actually a few problems here. This is a girl. This is an XX, okay? And that is a clitoris. It looks like a penis, obviously, but that's a clitoris. And the other problem is that there are no gonads, is what they're trying to say. So you got to look for the presence of the gonads, because obviously girls would have ovaries, which would be a lot higher. So there's nothing palpated. And the last problem is that the person doesn't have any gloves on, right? So that's icky. But yeah, that is interesting. But that's a little girl. So again, we talked about 11. You got to know 11. It's the block. So the DOAC is elevated. So they're going to get hypertension due to the accumulation. So they're going to have hypertension and then high levels of androgens. And then the 3 betas, that's really a high block, and they'll get high delta 5s to delta 4s, and we'll show you that. So the 3 betas are all up here, and these are the delta 5s and the delta 4s. So the DHEA is a pretty good androgen, so you can get ambiguity from that. Again, the 11s, the 11s are down here, and you're going to get the elevation of the deoxycorticosterone, so you're going to get the hypertension. Everything pushed over to the right, and you're going to get the ambiguity or the excess of androgens. But the 21 is the most common, okay? So if you're a salt waster, both of them are knocked out. A non-salt waster, only this one is knocked out, okay? So that's what you need to know for CAH. Another good one, ambiguous genitalia. Most common etiology for ambiguous genitalia in an XY baby is androgen insensitivity, CAH. 5-alpha reductase, mixed gonadal dysgenesis, and 17-keto steroid reductase deficiency. So you put your answers in. Very good. Androgen insensitivity. And the reason it's the most common is because of the whole spectrum. You can have complete insensitivity or partial, so it covers a lot. But yeah, again, always know the most common. That's always a good question on the boards. Okay, so we're going to talk about how little boys and girls are made, but it's not as exciting as you think, because this is the slide for how a little boy is made, okay? So I always like to know the normal, and then you can hopefully figure out the abnormal, okay? So you got this undifferentiated gonad, and it's this presence of this SRY, the sex-determining gene. It's usually it should be on the Y chromosome. That's what starts the ball rolling. Then you get your testes. Then you get your Leydig cells, which make testosterone, which support the Wolffian ducts. And then your Sertoli cells, which releases MIS, which inhibits the Mullerian ducts. Okay? Females, there's no SRY gene, so everything defaults to the ovary. So there's no testosterone, so you need testosterone to support the Wolffian ducts. So there's no testosterone, no Wolffian ducts. There are no Sertoli cells, no MIS, so the Mullerian ducts will form. Okay, so it's the presence or absence of that SRY gene. It's not estrogen. There's no need for any estrogen in this, right? It's the presence, again, the absence of the SRY. And that's important as you think about problems with ambiguous genitalia. Now, they've changed the name. It's more like PC now. They don't use these words, you know. It's supposed to intersex. We use the word disorders of sexual development. The male pseudohermaphrodite is a 46XY, disorders of sexual development. And then down the list here. So basically, there are 5 possible reasons why you're going to have ambiguous genitalia. You can have a problem with the sex chromosome. You can have 46XY, DSD. So that's either a problem with making the testes or the androgens, or recognizing the androgens. So it's either testicular disease itself, or if you can make the androgens, you know, it's a receptor problem. The 46XX disorder of sexual development, the ovotesticular, and then other. It's like that other. So 46XX, kind of like the overdone female, like there are too many androgens, okay? It basically, everything starts off fine. They're XX, right? So the gonad is the ovary. There's no sex-determining gene. There's no Wolffian ducts due to lack of testosterone. And there's no MIS, so the Mullerian ducts survive. So internally, everything's fine. It's externally that's the problem, okay, because they have too many androgens on board. Differential is really short, too many androgens, okay? And it's usually a lot easier to treat. Thankfully, it's more common because 100% of these kids are going to be raised as a female because they got all the internal organs for the female. They're ready to go. They just have to have surgery and then potentially be on some medicine to get their androgens lower, okay? Again, the differential diagnosis is CAH, and you just pray to the endocrine gods that they're going to be XX and CAH because, again, it's really relatively easy to treat. An adrenal tumor, obviously, that would be a cause for too many androgens. And danazol, that was always a good board question for a while. That was used to treat endometriosis in ladies. And the ladies were using it, and then they got pregnant, and it is it's an androgen. So they got pregnant not knowing it. They were on the danazol, and the baby got some androgen exposure. Okay, so that's a good board question. Sometimes they want you to know when the mom got exposed and how it's going to affect the baby. So if mom was exposed with androgens between 13 and 18 weeks, they'll just get labial fusion. If it's after 18 weeks, they'll just get clitoromegaly. But if it's kind of a continuum, they'll get the labial fusion and the clitoromegaly. So again, too many androgens in the boy, the lady. For the boy, it's a little bit more difficult. Again, it can either be a problem with the making of the testes or the androgens and the action of the androgens. Androgen insensitivity is the most common, but again, much more challenging relative to the XX baby. It's a lot more difficult to diagnose, and a lot of times you cannot raise them as males. Because if the problem is that they can't make androgens or they can't respond to androgens, like you can give them all the androgens in the world, they're not going to change. So not easy because sometimes they're XY and depends on the level of understanding and education of the parents, but you're like, they're going to have to be raised as a girl. Well, they're XY. Well, because of this problem, we're never going to be able to help them. So again, not an easy conversation, but thankfully most of them are XXs and CAH, and it's kind of easy to deal with. So some more syndromes for you. Get your 3x5 cards. If you have a defect in testicular differentiation, this Denny-Drash. So they're 46XY. Their testes just don't function. They are not normal. The Mullerian ducts are present because there's no MIS. And the spectrum they have is ambiguous genitalia, renal disease, and Wilms tumor. And this WAG that you've seen, again, with Wilms tumor, they'll have the Wilms tumor, the aniridia, the GU abnormalities, and mental retardation. So this gene, this copy of the 11p13, not only is a suppressor gene for Wilms tumor, but it also is required for testicular development. So that's another syndrome, important one to know. Defect in this Swyer syndrome, okay? Think SRY, okay? You see it in there sort of just mixed up the letters a little bit. Okay. Remember, the SRY is what's needed to get the ball rolling to make testes. So you're an XY, but because you don't have the SRY, you have gonadal dysgenesis. So there's no Sertoli cells, there's no MIS, there's no Leydig cells, there's no testosterone. The gonads are undifferentiated streaks, and the testes are low. Testosterone levels are low. And basically, they look like a female. They're XY female. Everything defaults to the female. But they don't have estrogen, so they don't ever get breasts. Okay, so gonads are at risk for malignancy, so you got to get them out of there. But this is the picture that I like. So you start off, you have the undifferentiated gonad, and they're XY, but there's no SRY. So the gonad just becomes dysgenic, doesn't do anything. Okay? So then there are no Leydig cells, so there's no testosterone. So there's no Wolffian ducts. There's no Sertoli cells, there's no MIS, so there are Mullerian structures. So it's just like a female, right? So the bottom line, this is an XY female phenotype, no breasts though, and no menses, and low testosterone levels because they have gonadal dysgenesis. And it's important to differentiate. This is, I know, a lot to like digest, okay? But if you look at this picture and think about it, we're going to differentiate this with androgen insensitivity in a few minutes. Persistent Mullerian duct syndrome, absent of the MIS, but the Leydig cells are fine. So this classic presentation, these kids come in and they're normal males, okay? XY, completely virilized, but they have Mullerian ducts inside of them because they never had the MIS forming. And when do you find these Mullerian ducts? Well, the classic thing is when they have a hernia surgery. They have cryptorchidism, and they're getting that repaired. And the surgeon opens them up and says, oh, my God, there's a uterus and fallopian tubes in here, you know. So hopefully they take them out, you know, and then so that's the classic story. So if you start seeing that, you think, okay, they have that Mullerian ducts are still present, okay. Now, you got to get them out of there because potentially fertility could be affected, you know, if there's the vas deferens are caught up in the Mullerian ducts. So again, this schematic is an undifferentiated gonad, SRY gene. They make the testes, they make Leydig cells, they make testosterone, they have Wolffian ducts. They look like a normal male, but they, for some reason, the MIS never forms, and they have the Mullerian duct. So the bottom line is an XY normal male with Mullerian structures found incidentally on hernia surgery or cryptorchidism. Okay. So I always say, for you guys that never had that surgery, you just never know what's inside of you. And then the androgen insensitivity, okay? It could be total insensitivity to partial, so that's why it's the most common. And it depends, again, on the degree of insensitivity. The buzzword is this blind vaginal pouch, okay? I'm going to go to the schematic right away, so it's a little easier. So you have the undifferentiated gonad, you have the SRY gene, you have a testes, you have Leydig cells. You make testosterone, the Wolffian ducts are supported, but the androgens don't work because it's a receptor problem. Okay, the androgens are floating around, but they're not working because you need a receptor to make them work. The Sertoli cells release MIS, so the Mullerian ducts are inhibited. Okay, so it's an XY, right, because you have the SRY, with female external genitalia, but no internal because the MIS is working. Okay, so they have androgens, they have a testes, they have high levels of androgens, but it's just not recognized because the receptor doesn't work. Okay, so when you think about XY female. It could either be Swire or androgen insensitivity. I know this is a lot after all this, okay, but Swire, XY with gonadal dysgenesis because the SRY is gone. The pathology for androgen insensitivity is a defect in the androgen receptor. So this is Swire complete female, internal and external. Androgen insensitivity is just that blind vaginal pouch, but they have the MIS, so they don't have any internal organs. Their testosterone levels are low because their gonads are undifferentiated. But with androgen, their testosterone levels are high because their gonads are testes. Okay. So that's a good board question. I know a lot to digest, but I think if you look at it a few times, hopefully you'll understand it. Two other ones, gonadal dysgenesis, X45X, 46XY, can present as Turner syndrome. This is one, again, you got to remove the gonads because of the risk of cancer. Now, the hermaphrodite is called an ovotesticular disorder of sexual differentiation. To be a hermaphrodite, you have to have both ovarian and testicular tissue present. They're usually XX, and it's hard to explain, but it's the tissue that has to be present that makes them this hermaphrodite. Okay, we're getting there. Poly's PCOS, a few slides on this. 16-year-old female, hirsutism and amenorrhea, menses at age 12, but never had regular cycles. She has acne, and OTC meds is not treating her acne. She's obese with severe scarring acne and hirsutism. You suspect PCOS. Initial labs, total and free testosterone, FSH, LH, DHEAS, 17-OHP. Second choice, thyroids, testosterone, prolactin, estradiol. Third, FSH, LH, thyroids, cortisol, DHEAS. 17-OHP, estradiol, prolactin, insulin. Or the last choice, total and free testosterone, insulin, prolactin, estradiol. Yep, very good. The correct answer is A. I'll talk about that in a minute. PCOS is kind of confusing. I mean, initially it was just a description of the signs and symptoms that Stein-Leventhal had seen. They had cystic ovaries, they were amenorrheic, they tend to be a little hairy, they were heavy, and when you did labs on them, they had high androgens, high testosterone, and high LH relative to your FSH. And the diagnosis is, they're trying to get a little bit more precise. There was this NIH conference in 1992, and they had a definition of otherwise unexplained chronic hyperandrogenism and poor ovulation, oligoovulation. This Rotterdam criteria, it's actually a measurement of the ovaries, and if it's greater than 10.8 cc's and with 10 follicles in a plane. Insulin resistance, obesity is not necessarily part of the diagnostic criteria. So with that being more popular and then all that CAH and androgens being more popular, it has gotten a little messy trying to figure out what's going on, okay? So again, your job, you're going to see this kid and they have evidence of hyperandrogenism, the hair and the acne and the irregular menses. So where could they, my approach to it is like, where are they getting the androgens from? Are they getting it from their ovary, which is the most common? Or are they getting it from their adrenal gland? Because if they're like a late onset CAH or an adrenal tumor or something, then they need certain treatment. If that seems to be normal, then it's probably PCOS, and you just treat them with birth control pills. So again, your job is to try and figure out, is it the adrenal gland? Because the treatment is different if it was from the ovary, okay? And it's also important, you got to get on this, because if you're not having regular cycles by 2 to 3 years, you're at risk for abnormal ovulation and fertility problems. Okay, so you do, not that fertility is an issue in adolescence, right, but eventually they're going to want to be fertile. So you want to recognize that and have them come in. And one of the problems is it runs in families, so a lot of times people just sit on it forever, and everyone has it, and in the family. And that doesn't mean it's normal, but it's sort of like, oh, that's the way it is in our family. So hopefully they're bringing them in, to see you. So again, when you're looking for PCOS, you're looking for the IUGR at birth. That puts them at risk. That premature adenarche, remember a certain percentage of those kids go on to PCOS, so you ask about that. You're looking for hirsutism, male pattern alopecia, acne, clitoromegaly, increased growth velocity, menstrual abnormalities, all those things you're looking for. But again, so they have hyperandrogen. Where is it coming from? Is it coming just like with the little boy with the hyperandrogen, adrenal or testes? With the girls here, is it the ovary that's causing it, or is it the adrenal gland? So some of the ways you can do, if you get a total and free testosterone, well, they're both elevated. They'll be elevated in both PCOS and adrenal disease, okay? A DHEAS, that's a good screen for an adrenal tumor. So if that is sky high and everything else seems normal, maybe you want to get an adrenal ultrasound. An LH to FSH ratio, it's about 3 to 5 to 1, 3 to 5 LH to 1 FSH. So if you have high levels like that, you would think about PCOS. Androstenedione is another good screen for an adrenal tumor. So if that's high, look at the adrenal gland. 17-OHP is a good screen for CAH. Prolactin, again, often prolactin is thrown in there, but that's really more of a screen because of their irregular periods. Same thing with the thyroids. You're really looking for amenorrhea and not necessarily for the hirsutism and the adrenal issues or the androgen issues. You can get a bone age if they're still old enough, they're young enough, you can get a bone age and a pelvic ultrasound. So some of those things will help you point in the direction, whether or not, again, you have to concentrate on the adrenal gland or the ovary. If you're worried about the adrenal gland, then I take care of it, and I usually do an ACTH stim test looking for late onset CAH and or an adrenal imaging. If the adrenal gland doesn't seem to be the problem, then, GYN will take care of them and put them on birth control pills and watch them closely. Sometimes I have to be on anti-androgens like spironolactone or something like that to help with all the hirsutism. Okay, Cushing. 9-year-old presents to the clinic, concerned about her weight. Parents said she's gained 20 pounds in the past 8 months. She's otherwise healthy, denies chronic illness. Her exam is significant for hypertension, central obesity, stria, and muscle weakness. And you are concerned about Cushing's. The best test is a morning cortisol, high-dose dex suppression, 24-hour urinary-free cortisol, low-dose dex, or an ACTH stim test. And put your answers in. Ooh. It's just the end of the day. Okay, so we'll talk about this a little bit. The best test, 24-hour urine for urinary-free cortisol. Okay. We talk about cortisols. We always talk about getting cortisol in the morning. Because what happens? Cortisol goes up in the morning and then it goes down. Okay. So Cushing's is high cortisol like all the time, right? So actually, if you're going to get a cortisol, it's probably best to get it in the afternoon because it should be low. And with Cushing's, it's high in the morning and high in the afternoon, right? If you're worried about adrenal insufficiency, which is low cortisol, you'd want to get the morning cortisol. Because, again, with adrenal insufficiency, you're low all the time, where, again, you should be high in the morning. So the morning cortisol is good for insufficiency, but not good for Cushing's. We'll talk about the other stim tests and stuff in a little bit. I think the part about Cushing's that's hard, when they say Cushing syndrome, they kind of lump the Cushing syndrome and Cushing disease together. Okay? So Cushing syndrome is specifically the adrenal problem. It's like an adrenal tumor. The Cushing disease is the pituitary disease. And that tends to be in the older kids, and the Cushing syndrome tends to be in the younger kids. So a lot of times you say, oh, I think they have Cushing's. They kind of lump them together. Oh, I'm worried about Cushing's. And so if you end up figuring out they do have high cortisol levels, and they do have Cushing's, then you have to figure out, is it the disease or is it the syndrome? Because if it's the disease, they usually have like a pituitary tumor. And then if it's the syndrome, they have an adrenal tumor. So they kind of lump them together. So that sometimes those kind of semantics make it a little bit confusing. So Cushing's, disease, or syndrome, okay? So first you have to make the Cushing's, what kind of signs and symptoms do you see? Well, they're short and fat. Okay, we talked about that before. They gain weight and they don't grow. They do not grow, okay? Then they always say, oh, that buffalo hump, you know, that's like only in 28%, or the stria is only in 36%, or the hypertension is only in 63%. It's really a short fat, okay? So you got to get out your growth curve and watch their weight going up and their height going down, okay? And that's the thing, you know, a lot of people, they'll send me these kids and they'll say, I'm worried about Cushing's because they're so heavy. And so I say, well, how tall are they? And they're like, well, they're tall. And I said, well, it's not Cushing's, you know. That's really the bottom line. Because, again, exogenous obesity, when you eat a lot, your insulin level goes up. When your insulin level goes up, that's a growth factor. So kids that are heavy with exogenous obesity tend to be kind of tall, right? So if you give me a growth curve and you got somebody who's heavy but who's tall and is growing appropriately in height, it's not Cushing's. Cushing's are heavy and they do not grow. They fall off the growth curve. They have a poor growth velocity. So again, Cushing's syndrome, short and fat, obesity, tall and fat, okay? Again, we talked about this. The normal cortisol, high in the morning, low in the afternoon. So for Cushing's, you'd be high in the morning and high in the afternoon. For insufficiency, you're low in the morning and low in the afternoon. But again, the best test is a 24-hour urinary-free cortisol. Okay, you want to do it over the 24 hours. Now, if you're not sure about that, if that doesn't really give you the answer, you could do a low-dose dexamethasone. And you give dexamethasone, like a milligram at 2,300, and the next morning you check the cortisol. If the cortisol level suppresses down, that's normal. It's just their obesity that's causing their higher cortisol level. And if you can't suppress it, you could potentially have Cushing's. And then you're going to have to do the ACTH or the CRH or the high-dose dex to try and differentiate the syndrome versus the disease. But again, for you guys, 24-hour urinary-free cortisol is the best test. If you have to check a cortisol, check it in the afternoon, and that would be high at that point. But again, the low dose you can also do to sort of suppress and see, but then we tend to do the high dose because that or the CRH are going to differentiate syndrome versus disease. Okay. Imaging, if you're worried about it, you can do a CT of the adrenal gland or an MRI to look for an adenoma in the pituitary. And there's one syndrome, Carney complex. They have the adrenal gland is pigmented and nodular. They can have Cushing's. They have blue nevi and cardiac and skin myxomas and schwannomas and the melatonin schwannomas. So, I don't know. I've never seen it. I don't know if that'll be on test, but another syndrome. Okay, getting there. Adrenal insufficiency. This is a classic presentation. A 14-year-old male, fatigue, muscle weakness, and chronic nausea. He's had some difficulty with walking. He's fallen 3 times in the past week. His exam is remarkable for tan. Always, that's a big buzzword for something in the adrenal gland, right? 4 out of 5 strength and ataxia. His sodium's low, potassium is high, and his AM cortisol is 3, which is low. So he has Addison's, adrenoleukodystrophy, CAH, histo, or adrenal hemorrhage. And you can answer those up. Oh, okay. What? Adrenoleukodystrophy. Oh, man. It's definitely wrong with his adrenal gland, but there's also something wrong with his neurological system. Years and years and years ago, there was a movie called Lorenzo's Oil, which is what this was about. A lot of the studies of this disease is done at Johns Hopkins, and it was about a family that was trying to find a cure for their kid. But this is the classic presentation. They get very long-chain fatty acids deposited in their adrenal gland and then their CNS. And it's usually a boy. Girls can get it, but it's usually much milder. And they start having problems with their nervous system, usually the ataxia, and then eventually their adrenal gland gets affected. So, again, why do they give you all that information? Most common reason, again, is Addison's for adrenal, but that doesn't really explain the neurological. So, there's another board question for you. You'll get that one right. So when you're talking about adrenal insufficiency, you got to worry about primary versus secondary. Primary is the gland itself. So with that, all axes of the cortisol are affected. And the reason you get tan with that is because of this POMC. It's a big, huge molecule. It has in it ACTH and melanocyte-stimulating hormone. So when your cortisol level is low, your POMC goes up, so your ACTH can go up, but that also gets the melanocyte-stimulating hormone up, and then you get tan. Okay? So the buzzword is tan. With secondary adrenal insufficiency, again, the central problem, the problem isn't with your, you're not releasing ACTH or the POMC, so you do not get tan. So that's the difference. I think one time I was confusing the residents because every time in the ICU, everything that's central is primary. And so, but in endocrine, the primary stuff is the organ itself, and the secondary stuff is the central stuff. So, but yeah, so again, with something wrong with the gland, primary, you're feeding back to the hypothalamic pituitary axis, high POMC, high ACTH, high melanocyte. So look for that buzzword, that tan, and they'll be talking about something in the adrenal gland. Other things that can cause primary is adrenal hemorrhage from maybe a difficult birth or asphyxia. If a baby that's born with really bad birth, they have scrotal hematomas, potentially they're going to have an adrenal bleed also. The Waterhouse-Friderichsen syndrome with the meningococcemia, and then child abuse can cause an adrenal hemorrhage. Ketoconazole can inhibit adrenal enzymes. Rifampin, phenytoin, and phenobarb can increase the metabolism and, again, cause adrenal insufficiency. We talked about the APS1. First, you get the candidiasis, the hypoparathyroidism, and the Addisons. Okay. Again, this is not MEN. This one is not associated with HLA, and males equals females. First is APS2, which is diabetes, thyroid, and Addison's. And there is that HLA because of the diabetes, the DR3, DR4. And again, don't get confused with MEN with this. Infections can cause it, CAH, infiltrative diseases. But that adrenoleukodystrophy, again, very long-chain fatty acids, which you can measure. And it's a boy, 5 to 15. They start having school problems, behavioral problems where they had been okay, dementia, vision loss, clumsiness, and again, adrenal insufficiency in 50%. And if you do an MRI, they have the periventricular demyelinization. But again, those very long-chain fatty acids get deposited, and that's what causes all their problems. Now, if you're on steroids and you start withdrawing them, if you withdraw them too soon, they're going to get a lot of signs and symptoms. Excuse me. Nausea, vomiting, but no diarrhea, okay? So that's a whole different differential when you have the nausea and the vomiting without the diarrhea. They get tired, they have poor appetite, muscle weakness, excuse me, hypotensive, rapid heart rate, so they're getting a little shocky. Again, there's nothing wrong with their mineralocorticoids, just their glucocorticoids. So they have low glucose, low sodium, but normal potassium. Excuse me. How do you avoid this? Wean slowly. If you wean too fast, they're going to get this. Just go slow in your wean. And there's no magical number. What I usually do is kind of double the amount of time that they've been on the steroids and wean according to that. If they've been on it for 2 months, they're going to wean over 4 months. I mean, it's just going to be kind of a slow wean to avoid this. And again, good education with the family. If you start having these kind of signs and symptoms, please let us know because we mean to go back up on the steroids again. If they have primary adrenal insufficiency, again, they're going to think of this with the weak and dizzies. I mean, you get the weak and dizzy teenager in all the time, right? And you check for anemia and you check for thyroid, but check for cortisol. Get that morning cortisol because they can be weak and dizzy, and that's because of their cortisol level being low. They have decreased energy, again, nausea and vomiting without diarrhea. Okay. And they're potentially salt craving, so they like pickle juice. So if they start all of a sudden there's no pickle juice in the house, all the pickles are put aside and they're drinking all the juice, that might be a sign. But again, think about this one in the weak and dizzies, though, because you might pick it up. Again, adrenal insufficiency, a low cortisol of less than 5, especially if they're under stress. I'm sorry. If you have a random cortisol greater than 20, this is going to usually rule out the disease. And sometimes you have to do an ACTH stim test to try and figure out, if they are deficient. If you give ACTH and the cortisol remains low, then there's something wrong with their adrenal gland. Okay. If you have low cortisol, which increases a little bit with ACTH, that usually means there's a problem with their central disease. Okay. Again, low sodium and high potassium has to do with aldo. So you only have aldo deficiency with the primary adrenal disease. Okay. Theo, just a few more slides. We're almost done. With primary catecholamines elevated in a child with a Theo, epi, norepi, cortisol, aldo, testosterone. And put your answer in. Oh, very good. Norepi, very good. Good answer. Okay, catecholamine secreting tumor of the chromaffin cells, usually in the adrenal medulla, but they can be along the sympathetic chain, most likely at the aorta, at the bifurcation, or the inferior mesenteric artery. 1 in 5 are bilateral, but majority of them are going to be at the right side of the body. There are associated syndromes associated with the neurofibromatosis, tuberous sclerosis. You can read those. Okay. Not very common. I mean, we've looked for it. I've never seen it. Okay. But everyone worries about it. With kids with high blood pressures, adults have the paroxysmal. They go up and down. Kids could be sustained or paroxysmal. Headaches, palpitation, dizzy, sweaty. They don't grow well, even though their appetite is good. And their blood pressure is like out of this world. Okay. And they can have eye disease as a result of the high blood pressure with the exudates and the hemorrhages, papilledema. Again, norepi in kids, it's epi in adults. And you can also, obviously the VMA and the metanephrines are also elevated. But again, it's more going to be the metanephrines with the norepi in the kids. So how do you ultrasound, and then you got to look for it. If it's not in the adrenal gland, if it's in the parasympathetic chain there, along there, it's kind of hard to find. So that's when you do the MIBG study. It's a nuclear medicine study, and this MIBG is only picked up by the chromaffin cells. So it makes it a little bit easier to try and find it if it's outside the adrenal gland. And again, if you do surgery, you're going to have to give alpha and beta blockers to control the blood pressure. Finally, aldo. So aldo. So the syndrome associated with hypertension, hypokalemia, low renin, and low aldo is Barter, Little, Gittleman, Cushing, Carney. So best guess. Hope nobody says Cushing's. Don't say Cushing's. Oh, very good. It's one of those three. Somebody said Cushing's. Who did that? Just so you know, you just wanted to see your just little ditzel up there, right? No, there it is. That's me. But that is Little or Lytle syndrome. Okay. Mineralocorticoid excessive. You can have what they call primary hyperaldo, where it is a tumor. Okay. Basically, you're spitting out a bunch of aldosterone independent of the renin-angiotensin system. Again, primarily it's going to be an adenoma. Unilateral adenomas are seen in girls, but for boys it tends to be bilateral. And again, they can have just hypertension, they can have headaches or dizziness, hypokalemia, nocturia polydipsia. And again, their potassium is low, their renin is low, but their aldo, because they're secreting this, is very, very high. So how you diagnose it, the first thing you do is actually more of a diagnostic and potentially a treatment, is that you give dexamethasone, because there's an entity called dexamethasone suppressible hypoaldo. And if it suppresses, then that's the diagnosis, and that's how you treat them. You treat them with steroids. If it does not suppress, if the aldosterone does not change after giving dexamethasone, then you're going to do a CT to look for an adenoma. And then if that's negative, then you're going to have some radiologist, interventional radiologist, stick a catheter in the adrenal vein. And you're going to look for the differential between the right and left adrenal gland. Because if there's high concentration of aldo on one side, it's an adenoma that you missed. If it's high concentrations on both sides, it's adrenal hyperplasia. So again, treatment, if it's the glucocorticoid one, you treat with prednisone. If it's an adenoma, you treat with surgery. And if it's bilateral adrenal hyperplasia, mostly treat with spironolactone. If it's secondary, the renin-angiotensin system is not suppressed. The renin levels are really high, usually due to some volume problem like nephritic or CHF or cirrhosis, some edematous sort of state. Or it could be due to an adrenal artery stenosis, Wilms tumor, or something that's producing excessive renin and then subsequently increasing up the aldo. And the last three syndromes you need to know, Barter, they have high aldo, high renin, but no hypertension. And the buzzword for this is the polyhydramnios and the calcium, urine calcium in the urine, and then subsequently kidney stones. The Gittleman, they have high aldo, high renin, normal blood pressure, and they get hypomagnesiemic and hypocalcemic. And then the Lytle syndrome is high blood pressure, low renin, low aldo, and you treat with sodium restriction and potassium sparing diuretic. And that is the end.